Welcome to Deep Dive Ortho. We're the deep dive that aims to get right under the skin, exploring the intricate marvels of the human body. Today, we're looking at a tissue that, well, despite its absolutely fundamental role in our movement, our comfort, it's often really misunderstood. Cartilage, it's often called the unsung hero of our joints, isn't it? Providing that essential cushion, that incredibly smooth glide, yet we tend to ignore it until it's seriously compromised. And what might seem like just a simple, maybe slightly inert substance is actually, when you look closer, a marvel of biological engineering. It's packed with unique properties that define not just its amazing function, but also its significant vulnerabilities. And these create real challenges in orthopedic practice. To guide us through this intricate and clinically vital deep dive, we have Professor Mo Imam with us. He's here to offer really unparalleled, in-depth insights into cartilage, its fundamental nature, its complex structure, its remarkable biomechanics, and crucially for us as clinicians, the big clinical implication, including the latest in diagnostics and regeneration. Professor, our mission today really is to thoroughly unpack cartilage for our audience of fellow medical professionals. So let's start right at the beginning. When we talk about cartilage, what exactly are we defining? It often gets simplified, but there's so much more to it, isn't there?
Thank you. Yes, it's a really crucial starting point because, while the average person might just think cushion, cartilage is vastly more sophisticated than that. Fundamentally, it's what we call a heterogeneous connective tissue. That means its makeup, its mechanical properties, they aren't the same all the way through. And this variation, in its thickness, its stiffness, it's precisely adapted to handle the different kinds of compressive forces and support the key biomechanical jobs within different joints. Just think about its roles. It's engineered to resist huge compressive loads, which helps the underlying bone be more resilient. It gives essential support where flexibility is needed. It acts as a fantastic shock absorber. And maybe most famously, it creates this incredibly low-friction sliding surface. That's what allows the smooth, easy movement we kind of take for granted every day.
It really is multi-talented.
It is. But for us, clinically speaking, what really sets cartilage apart and what profoundly shapes our approach to its problems are its defining biological features. I sometimes call them the A factors. It's a vascular, annular, and lymphatic.
The three A's.
Exactly. And these aren't just, interesting biological facts. They are the fundamental constraints that really dictate almost everything about how we manage cartilage issues clinically. Let's take vascularity first. Unlike most tissues in the body, cartilage has no direct blood supply. None at all.
Which is quite remarkable when you think about it.
It is. It means the chondrocytes, those are the cells that maintain the cartilage matrix they have to get their nutrition and get rid of waste products, mainly through diffusion. This happens mostly from the surrounding tissues, particularly the synovial fluid that bathes the joint. For some types, like elastic or fibrocartilage, the perichondrium, that fibrous layer covering non-articular cartilage, also plays a part.
So no direct delivery system.
Seriously. And this lack of blood vessels isn't just a detail, it's the primary reason why cartilage has such a notoriously limited ability to heal itself. It's why recovery after an injury is so frustratingly slow. It basically means that often we're not trying to help natural repair, but we're thinking about ways to augment it or even replace the damaged tissue.
Right. That makes sense. And the second A, annular.
Yes, annular. Cartilage contains absolutely no nerves. Zero.
Okay.
And this has really critical clinical implications. If a patient comes to you with pain they think is from cartilage damage, that pain isn't actually coming from the cartilage itself.
Because it can't feel anything.
Exactly. The pain originates from irritation of the surrounding structures that do have nerves, like the joint capsule, the synovium, or the subchondral bone underneath the cartilage.
Ah, so it's an indirect pain signal.
Precisely. It's a really common thing in conditions like osteoarthritis, but it's often misunderstood. The pain is a result of the wider joint problem. The inflammation, the bone changes, maybe impingement, not pain, signals directly from the damaged cartilage.
Which probably explains why patients sometimes present quite late, doesn't it? When the damage is already significant because they haven't felt it earlier.
That's often the case, yes. The pain only starts when those surrounding structures get involved, which means we can sometimes be, a bit behind the curve in terms of intervention.
And the third A, alymphatic.
Alymphatic, yes. It just means it lacks lymphatic vessels, which are part of the system for fluid drainage and immune response in other tissues.
Yeah.
So when you put all these A factors together, a vascular, annular, lymphatic, it becomes really clear why cartilage's ability for self-repair is so limited and why recovery after injury is so slow and often incomplete.
Mm-hmm.
For us as clinicians, understanding these fundamental biological limits is absolutely essential. for diagnosis, for planning treatment, and maybe most importantly, for managing patient expectations about recovery and long-term results.
That's a very powerful framework. It really does highlight why our strategies often focus on preventing more damage, or why we end up considering quite complex reconstructive procedures for significant injuries, rather than expecting the kind of natural repair we might see in, say, muscle or skin. So, given these profound limitations, it really begs the question, what is this tissue actually made of? How is it structured to function so well under load, even with this poor healing ability? Let's get into the building blocks.
Exactly. The story of cartilage's resilience and its challenges, it's all tied up with its cellular architect, the chondrocyte and the amazing extracellular matrix, the ECM, that it builds and maintains. The chondrocyte is the main, and in mature cartilage, pretty much the only cell type you find.
Just one cell type doing all the work?
Essentially, yes. These cells live in little spaces called lacunae, and their main job is a constant dynamic process. They produce, secrete, and meticulously look after the ECM all around them. It's quite a feat when you realize how sparsely distributed they are. They only make up about 1 to 5% of the total cartilage volume. They're really the hidden workhorses.
Tiny fraction, huge responsibility.
Absolutely. And what's also interesting is their little neighborhood, their microenvironment. Each chondrocyte creates this specialized matrix right around itself, which effectively traps it in its lacuna.
Traps it.
Yes, it prevents the cell from moving to other areas, which, as we just discussed, contributes to that limited repair capacity. If there's damage nearby, the neighbors can't just migrate over to help fix it.
Right, they're stuck in their spots.
Exactly. And metabolically, they live in quite tough conditions. They get a low supply of nutrients, reduced oxygen. It's almost hypoxic, actually, and often an acidic environment. So they primarily rely on anaerobic metabolism for energy. Interestingly, giving them more oxygen can actually inhibit their function. It shows how uniquely adapted they are to this specific low-oxygen niche.
Fascinating. And how do they get there in the first place? Chondrogenesis.
Yes, chondrogenesis. That's the process where cartilage forms and involves mesenchymal stem cells, MSCs, differentiating into these specialized chondrocytes. Key transcription factors like SOX9 are really crucial in guiding that process. But, and this is another key point for healing, once they are mature chondrocytes in adult cartilage, they have very limited ability to divide and replicate. Another major factor in why cartilage repair is so poor.
Okay, so we have these specialized, somewhat isolated, long-lived cells. What about the stuff they build, the ECM?
Ah, yes, the extracellular matrix. That's the star of the show in many ways. It makes up the vast majority, 90 to 95%, of the cartilage volume. It's what primarily determines cartilage's unique mechanical properties. And it's mainly composed of three things: water, collagen, and proteoglycans.
Water, collagen, proteoglycans.
Water is easily the most abundant, making up 60 to 80% of the wet weight. And it's not just filler, it's absolutely vital. It transports nutrients in, carries waste out, provides lubrication for smooth joint movement, and crucially, it's a primary way cartilage supports load. There's something called fluid pressurization. We can talk more about that when we get to biomechanics. This high water content also gives cartilage that sort of plump resilience.
Okay. And collagen. I usually think of collagen providing toughness.
That's exactly right. Collagen provides the tensile strength, the resistance to pulling forces, and it forms the structural framework, like scaffolding. In hyaline cartilage, that's the most common type in joints like the knee or hip, type 2 collagen is king. It makes up 90–95% of the collagen there. In fibrocartilage, like in the meniscus or the spinal discs, you find a lot more type I collagen, which is geared towards resisting high tension and compression.
So different collagen types for different jobs.
Precisely. And all collagen has that characteristic triple helix structure, which is what gives it its strength, shear, and tensile properties and helps stabilize the whole matrix. Incredible structural integrity.
And the third component, proteoglycans. They sound important.
They're incredibly important. Proteoglycans, PGs, and their attached glycosaminoglycans, GAGs. These molecules are vital for compressive strength, resisting squashing forces, and critically, for attracting and holding onto that water within the matrix. The main proteoglycan in articular cartilage is called aggrecan. It's a huge molecule, and it's amazing because it can link up with another molecule, hyaluronin or HA, to form these massive aggregates. Superstructures, really.
Aggrecan, aggregates, okay.
And the way aggrecan works biophysically is fascinating. It's polyanionic, meaning it has lots of negative charges from sulfate and carboxylate groups along its chains.
Negative charges, like magnets.
In a way, yes. These negative charges attract positive ions, like sodium, from the surrounding fluid into the matrix. This creates a strong osmotic pressure, which actively sucks large amounts of water into the matrix, making it swell up.
Ah, so that's how it holds so much water.
Exactly. And this swelling pushes outwards against the collagen network, which resists the expansion. This creates a sort of internal pressure, or turgor, that strongly resists compression. It's like a very sophisticated water balloon reinforced with strong fibers.
That's a great analogy.
Attached to aggrecan are the JAGs, like chondroitin sulfate, CSC, and keratin sulfate, KS. Chondroitin sulfate in particular contributes to cartilage's sort of rubbery consistency and resilience, its ability to bounce back after being squashed. And hyaluronan, as I mentioned, acts like the central backbone, stringing these huge aggregate molecules together into those massive aggregates. This structure is crucial for the ground substance and for that amazing shock absorption.
So if we link this back clinically, this intricate arrangement isn't just random biology, is it? It's pure engineering to withstand forces.
Absolutely. It's a masterpiece of biological engineering. And it's not just the components, but how they're organized. This zonal structure, especially in articular cartilage, is particularly fascinating and directly impacts how cartilage handles load and how injuries might develop. Articular cartilage, which is typically about 2 to 4 millimeters thick, is organized into 4 distinct layers, like a laminate. Each layer is exquisitely adapted for the high-stress environment inside our joints.
4 layers. Okay, let's break those down.
Right. At the very top, interfacing with the joint fluid, is the superficial zone or tangential zone. It's about 10–20% of the thickness. Here, the chondrocytes are flattened, kind of squashed looking, and the collagen fibers, mostly type 2 and also some type 9X, are packed really densely and run parallel to the surface, like sheets laid flat.
Parallel to the surface. So that resists shear
Right.
gliding forces.
Precisely. It protects the deeper layers from shear stresses during movement and gives the surface its tensile properties. It's also key for lubrication, being right next to the synovial fluid. When you see early degenerative changes like fraying or fibrillation on an arthroscopy, it's often this superficial zone that's affected first.
Okay, zone 1, shear resistance. What's next?
Beneath that is the middle zone, or transitional zone. This is the thickest layer, making up maybe 40–60% of the volume. Here, the chondrocytes are more rounded, sort of randomly scattered, and the collagen fibrils are thicker and arranged more obliquely, less organized than the surface layer. Think of it like a meshwork. This zone also has a very high content of those water-loving proteoglycans.
So less organized collagen, more proteoglycans. What's its main job?
It acts as the first real line of resistance against compressive forces. It sort of bridges the shear-resistant superficial layer and the really compression-resistant deep layer below it. It helps distribute the stress downwards and outwards.
Okay, middle zone, transition and compression resistance.
Deeper still is the deep zone, or radial zone. This is about 30% of the thickness. Here, you see large, round chondrocytes, but they're often stacked up in columns, running perpendicular to the joint surface, pointing down towards the bone. And the collagen fibrils here also run perpendicularly.
Columns pointing down, like pillars supporting the load.
Exactly like pillars.
Mm.
This zone has the highest concentration of proteoglycans and, interestingly, the lowest water concentration when it's not loaded. This structure gives it the greatest intrinsic resistance to compressive forces. It's beautifully designed for transmitting load down to the bone.
Highest proteoglycans, lowest water, perpendicular structure, maximum compression resistance.
Right.
And the last layer.
The final layer is the calcified zone. This sits right on top of the subchondral bone, the bone underneath the cartilage. It's separated from the deep zone by a distinct boundary called the tide mark. Pathologists sometimes call it the blue line. Its main job is to anchor the cartilage firmly to the bone. Those perpendicular collagen fibers from the deep zone actually cross the tide mark and embed into this calcified layer, locking it down.
Like the roots of a tree anchoring it in the ground.
A very good analogy. You find fewer chondrocytes here, and they tend to be hypertrophic, and the matrix is, as the name suggests, calcified. This zone is crucial for the mechanical connection between cartilage and bone.
Okay, 4 distinct zones, each with a specific structure and function. That's already complex.
But wait, there's more. Even within the matrix around the chondrocytes, there's further organization into microregions, based on how close they are to the cell, their composition, and collagen organization.
Microregions too. Wow.
Yes. Briefly, there are 3. Right next to the cell membrane is the pericellular matrix. It's a thin, very hydrated layer, rich in certain proteoglycans and glycoproteins. It's thought to be involved in sensing mechanical load mechanotransduction and protecting the cell membrane itself from direct stress. Surrounding that is the territorial matrix. This has finer collagen fibrils forming a sort of basket weave around the chondrocyte and its pericellular halo. It's believed to offer further protection to the cell from mechanical forces, adding to the
Like
resilience.
a protective capsule.
Sort of, yes. And then the bulk of the ECM between these territorial zones is the interterritorial matrix. This is the largest region. It has bundles of larger collagen fibrils oriented differently depending on which main zone you're in, and it's packed with those aggregate aggregates. This interterritorial matrix contributes most significantly to the overall biomechanical properties of the cartilage.
Paracellular, territorial, interterritorial. It's incredibly intricate, layer upon layer of specific organization.
It really is. This whole hierarchical structure, from the macrozones down to the microregions, is what allows cartilage to be so robust yet flexible, to handle decades of load. A true masterpiece of biological adaptation.
Absolutely stunning detail. Okay, so we've taken it apart, looked at the cells, the matrix, the incredible architecture. Now let's put it back together in a living joint. How does this amazing tissue actually work day to day? And how does it sustain itself, especially without that direct blood supply? You mentioned it seemed paradoxical.
It does seem paradoxical, doesn't it?
Yeah.
But it's actually a very elegant biological solution.
Yeah.
The maintenance of cartilage, especially articular cartilage, relies heavily on diffusion for getting nutrients. Things like oxygen, glucose, growth factors, they mostly come from the synovial fluid bathing the joint. For the deepest layers, there might be a little bit of diffusion for the blood vessels in the subchondral bone underneath.
But diffusion alone sounds slow and maybe inefficient.
It would be if it were purely passive.
Hmm.
But it's not. It's a dynamic process that absolutely depends on joint movement and mechanical loading. These forces are fundamental for getting nutrients in and waste products out.
How does that work? The loading helps.
Yes, think of it like squeezing a sponge. When you load the cartilage during walking or bending a joint, you compress it. This physically squeezes interstitial fluid, along with metabolic waste products, out of the matrix.
Okay, squeeze out the bad stuff.
Exactly. Then, when the load comes off, as the joint decompresses, those powerful osmotic forces we talked about from the negatively charged proteoglycans actively draw fresh, nutrient-rich synovial fluid back into the cartilage.
Ah, the pump mechanism.
Yeah.
Load squeezes out, unload sucks in.
Precisely. This pump is absolutely vital for keeping the chondrocytes alive and healthy, and it directly explains the clinical idea of use it or lose it for cartilage health.
Right. Too much rest isn't good either.
No, prolonged inactivity or significant underloading can actually lead to the cartilage thinning, getting softer, losing proteoglycans,
Sure.
eventually leading to atrophy and degeneration. This is why controlled physiological loading, like from regular exercise, isn't just protective, it's essential for maintaining the matrix. Of course, excessive acute overloading can cause damage, so it's about balance.
Okay, so nutrition is load dependent. What about its actual mechanical job? Distributing load, low friction.
Right, its biomechanical functions. Firstly, it distributes mechanical loads over a wider area. This dramatically reduces the peak stress on the underlying subchondral bone, which is crucial for preventing bone damage over time. Secondly, it minimizes friction during movement. Healthy cartilage on cartilage has an incredibly low coefficient of friction, lower than ice on ice. This allows for that smooth, effortless joint articulation. Imagine the grinding without it.
Unthinkable, really.
And thirdly, it's a fantastic shock absorber. It buffers vibration and impact, protecting the bones from the repetitive microtrauma of daily activities like walking, let alone running or jumping. Mechanically, cartilage behaves as a viscoelastic tissue.
Viscoelastic, meaning it has properties of both a liquid, viscous, and a solid elastic.
Exactly. It means its response to load depends on time. It's often modeled as a biphasic material, two phases interacting. A fluid phase, which is mostly water and ions, and a solid phase, the porous ECM network of collagen and proteoglycans.
Okay, fluid and solid interacting.
Yes. So when you first apply a load, there's a rapid increase in the pressure of the fluid within the cartilage. This pressure itself carries a lot of the load initially. As the fluid starts to flow out of the matrix, it creates frictional drag against the solid matrix. This flow-dependent mechanism is a major way cartilage bears load, especially rapid loads.
So the fluid movement itself resists the force.
A significant part of it, yes. Then there's also the inherent viscoelastic behavior of the solid matrix itself, the collagen proteoglycan network resisting deformation. It's the combination of these flow-dependent and flow-independent mechanisms that allows cartilage to handle incredibly high cyclic loads. We're talking forces up to 10, even 20 times body weight during things like jumping or running, often with minimal damage in healthy tissue. That's why marathon runners' joints can potentially endure millions of impacts.
That's truly remarkable capacity. You also mentioned creep and stress relaxation.
Yes, those are classic viscoelastic behaviors. Creep is when you apply a constant compressive load. The cartilage continues to deform slowly over time as fluid flows out until it reaches an equilibrium state. Stress relaxation is the opposite. If you deform the cartilage and hold it at a constant strain, the initial stress required to hold it there gradually decreases over time, again as fluid redistributes and the matrix adapts until it reaches an equilibrium stress.
So it adapts to sustained loads or deformations.
Exactly. These properties show how cartilage adapts to varying loads over time, which is vital for everyday function, like standing or holding a position.
Okay, and what about the day-to-day maintenance, the metabolic activity?
Well, chondrocytes, as we said, are responsible for both synthesizing new matrix components and degrading old or damaged ones. It's a constant state of turnover, aiming for homeostasis or balance. And their activity level is tightly regulated by signals from their environment, both chemical signals, like pro-inflammatory cytokines, such as IL-1 and TNF-alpha, which can drive degradation.
The bad guys in inflammation.
Often, yes, in disease states, but also growth factors like IGFs and TGF-beta, which stimulate the building, the anabolic processes. Mechanical loading itself is also a powerful regulator of chondrocyte metabolism.
Right.
The balance between these anabolic and catabolic signals is absolutely critical.
And how fast is this turnover? You hear about bone remodeling being quite active.
Cartilage is the opposite extreme. The turnover rate of ECM components is incredibly slow. Proteoglycans might take up to 25 years to turn over.
25 years?
Yes. And for collagen, the estimated half-life ranges from decades to possibly even hundreds of years. Some estimates go up to 400 years.
Wow. So it's built to last but difficult to repair if that balance is upset.
Precisely. This extreme stability is great for long-term function, but it means that if degradation processes start to outweigh synthesis due to injury, inflammation, or age-related changes, the damage accumulates because the repair is so slow. That imbalance is the fundamental basis of diseases like osteoarthritis. The main enzymes driving degradation are matrix metalloproteinases, MMPs, things like collagenase, gelatinase, stromycin, and also enzymes called ODAM-TS plus catepsins. They break down the collagen and aggrecan.
So maintaining that balance is everything.
It really is. Which brings us to a really important clinical question. How does aging affect these incredibly stable yet dynamic processes? We know age is a huge factor in joint problems. What's happening at the tissue level?
That is the critical next step, isn't it? We've established it's built for durability, almost permanence, but clearly even cartilage isn't immune to the effects of time. So what exactly happens as we age? How do these subtle, maybe insidious changes contribute to the common, often debilitating joint conditions we see every day in clinic?
Yes, age-related changes in articular cartilage are a major contributor to musculoskeletal problems, especially osteoarthritis. As we get older, several key degenerative changes tend to happen within the cartilage matrix. Firstly, there's generally a decrease in the overall water content. Counterintuitively, perhaps, this actually leads to an increase in the compressive stiffness of the cartilage.
Stiffer. That doesn't sound good. Less shock absorption.
Exactly. It means the tissue is losing some of its natural elasticity and its ability to deform and distribute load effectively. It becomes more brittle, in a sense. We also see significant changes in the proteoglycans. The large aggregates tend to become smaller. And there's a very distinct shift in the ratio of the GAGs attached to them. Specifically, the ratio of keratin sulfate to chondroitin sulfate changes quite dramatically. It's about 10:1 Ks to Cs at birth, but shifts to roughly 2:1 in older adults. Keratin sulfate becomes more dominant.
And that affects its properties.
Yes, it alters the osmotic properties, the ability to attract and hold water. Plus, you get an accumulation of partially degraded hyaluronin, that backbone molecule. All this compromises the matrix's ability to resist compression effectively. On top of that, the matrix itself becomes more rigid overall. This is due to increased cross-linking between the protein and collagen fibers. They become more tightly bound together.
More cross-linking, more rigidity.
Yes, and this increased rigidity is a key reason why older patients might feel joint pain even before there's significant cartilage loss visible on an X-ray. The tissue itself isn't absorbing shock as well, so more force gets transmitted to the sensitive subchondral bone underneath.
And that bone can signal pain.
Exactly. This increased rigidity also makes the tissue more prone to calcification, especially in the deeper zones. And calcification is bad news because it further blocks that crucial nutrient diffusion pathway. Chondrocytes trapped in calcified areas eventually die, creating dead zones within the cartilage.
So the cells themselves suffer too.
They do. Chondrocyte function declines with age. Their ability to repair the matrix becomes less effective. While the total number of cells might stay relatively stable, their distribution can change fewer near the surface, perhaps clustering deeper down. But crucially, the reduced ability to synthesize new matrix and repair damage means that delicate homeostatic balance tips towards degradation.
And what does this look like structurally?
Macroscopically, these age-related changes show up as thinning of the articular surface. You start to see fibrillation, small surface cracks or fraying, and eventually deeper fissures and cracking. This obviously compromises the smooth surface and the load distribution. And the effects spill over to the subchondral bone. Because the cartilage isn't deforming and absorbing shock as well, the bone underneath takes more punishment. This can lead to changes like thickening of the bony trabeculae subchondral sclerosis, which you can see on X-rays, and often bone marrow edema or lesions visible on MRI, signaling stress and damage.
It all connects.
It absolutely does. This whole cascade is directly linked to the development and progression of osteoarthritis, OA. Aging is arguably the single biggest risk factor for OA. It's often called wear and tear, which is a bit simplistic, but it captures the idea that joints under long-term mechanical stress are most affected. The end result is that progressive thinning and wearing away of the articular cartilage. This leads to reduced joint movement, pain, and eventually that dreaded bone-on-bone contact we see in severe OA.
And it becomes a vicious cycle.
Very much so. The damaged degenerating cartilage can itself irritate the joint lining, the synovium, causing secondary inflammation or synovitis. This inflammation can further harm the cartilage and also lead to changes in the synovial fluid, making it less effective at lubrication and nutrition. Over time, chronic inflammation can cause the joint capsule to thicken and contract fibrosis, leading to stiffness and loss of motion. And the degenerated chondrocytes themselves can release enzymes and inflammatory mediators that actively worsen the cartilage breakdown. It really feeds on itself.
A truly complex and often self-amplifying process. That clarifies the progression so well. Okay, with this deep understanding, the structure, function, vulnerabilities, aging, let's pivot fully to the clinical landscape. What are the key pathologies we encounter that centrally involve cartilage? How are we diagnosing and managing them now? And crucially, given everything we've said about its poor healing, what does the future hold? What's on the horizon for repair and regeneration?
Right, this is where the science meets the clinic directly. Let's start with the big one, osteoarthritis, OAA. As we've discussed, while OA involves the whole joint, articular cartilage really takes the brunt of it. The core problem is that imbalance between matrix building anabolism and breakdown catabolism by the chondrocytes. This leads to excessive production of pro-inflammatory cytokines IL-1, TNF-alpha, and those matrix-degrading enzymes like MMPs and ADATs. They chew up the matrix and also inhibit new blood vessel formation, which ironically contributes to keeping the diseased cartilage vascular.
So how do we typically manage OA initially?
Initial treatment is usually conservative. Anti-inflammatory medications, NSAIDs, are common for pain and inflammation. Intra-articular corticosteroid injections can help calm down acute flare-ups of inflammation within the joint. But lifestyle measures are absolutely paramount. Sustained weight loss, even modest amounts, can significantly reduce joint load, especially in the knees and hips. Targeted exercise programs to strengthen surrounding muscles and maintain range of motion are vital. And sometimes activity modification using a cane or periods of rest are needed to reduce joint stress.
And when conservative measures aren't enough?
When symptoms severely impact daily life despite good conservative management, then we start considering more invasive options, typically joint replacement surgery, arthroplasty, or perhaps joint resurfacing in specific cases. One important point to mention, though, is arthroscopic surgery for knee OA. While it used to be common for cleanouts, multiple high-quality studies have shown it generally offers no significant benefit over non-surgical treatment for generalized OA, and it does carry risks, so its use in OA is now quite limited and generally not recommended.
That's a key point about arthroscopy. Okay, what other major cartilage pathologies do we see?
Another very common one, involving fibrocartilage this time, is spinal disc herniation. This is usually a degenerative process affecting the annulus fibrosus, the tough outer ring of the intervertebral disc. Age-related changes, or sometimes trauma like heavy lifting with poor technique, can cause tears or weakening in the annulus. If that happens, the softer, gel-like inner part, the nucleus pulposus, can bulge or extrude out herniae, usually backwards into the spinal canal.
And that causes problems by pressing on nerves.
Exactly. It can impinge on spinal nerve roots, causing the classic symptoms of radiculopathy pain, numbness, tingling, or weakness radiating down a limb. The damaged fibrocartilage itself can also contribute to local inflammation. Diagnosis is often clinical, based on the patient's history and a neurological exam, but MRI is usually used to confirm the herniation, see which nerves are affected, and rule out other causes like tumors or instability.
And treatment, is it always surgery?
Oh, definitely not. The vast majority of disc herniations actually resolve with conservative management rest, anti-inflammatories, physiotherapy, sometimes epidural steroid injections. Surgery is usually reserved for cases with severe or progressive neurological deficits or intractable pain that doesn't respond to conservative care over a reasonable time.
Good to know. And you mentioned a genetic condition earlier.
Yes, achondroplasia. This is quite different as it's a developmental disorder of cartilage formation, not degenerative. It's the most common cause of dwarfism. The underlying issue is a specific mutation in the FGFR3 gene on chromosome 4. This receptor normally acts as a brake on cartilage growth in the growth plates. In achondroplasia, the mutated receptor is permanently switched on, so it excessively inhibits chondrocyte proliferation and maturation in the growth plates. This leads to shortened long bones and the characteristic features of dwarfism.
And can we treat it?
Diagnosis is often made prenatally by ultrasound or clinically after birth. Unfortunately, there's currently no cure. It doesn't involve hormone pathways we can easily manipulate pharmacologically. There are some targeted therapies in development focusing on the FGFR3 pathway, but they are still emerging. Corrective surgeries, like limb lengthening, are possible, but they are very complex, involve long recovery periods, carry significant risks, and remain quite controversial.
Right. A very different challenge. Okay, let's talk diagnostics. You mentioned MRI being key. Can you expand on that? How good is it at actually seeing the cartilage?
MRI is absolutely central now for looking at articular cartilage non-invasively. It's far superior to X-rays, which only show bone well and infer cartilage loss from joint space narrowing, and better than CT for soft tissue detail, plus no ionizing radiation.
What specific things are we looking for on MRI?
Standard sequences give us good information. T1 weighted images give excellent anatomical detail and show the contrast between the dark cartilage and the brighter bone marrow fat. We can see the overall thickness, contours, and identify larger defects. T2 weighted images, especially fat-suppressed ones, are great because joint fluid shows up very bright. This gives an arthrogram effect, highlighting fluid filling any defects or tears in the cartilage surface. T2 mapping, a quantitative technique, can even measure the T2 relaxation time within the cartilage itself, which reflects changes in water content and collagen organization, potential markers of early degeneration before visible defects appear.
So we can see structure and even some hints about composition.
Yes, and there are even more advanced techniques pushing that further. Delayed gadolinium-enhanced MRI of cartilage, or DG-MRI, is one. Here, you inject a special type of gadolinium contrast intravenously. It's negatively charged. It diffuses into the cartilage, but because the proteoglycans are also negatively charged, they repel it. So areas with less proteoglycan, meaning damaged or degenerating cartilage, will take up more of the contrast agent.
Ah, so it maps out the GAG content indirectly.
Exactly. It gives us a biochemical picture, potentially identifying cartilage injury or early disease much sooner than standard structural MRI.
Yeah.
It's quite promising for tracking disease or repair.
Fascinating. Any others?
Another one being explored is sodium MRI, 23NA MRI. Sodium ions are closely associated with the fixed negative charges on the proteoglycans. By tuning the MRI scanner specifically to the sodium frequency, we can try to quantify the fixed charge density within the cartilage, which again reflects proteoglycan content and tissue health.
So really trying to assess the tissue quality, not just look for holes.
Precisely, but it's still challenging. Cartilage is thin, its structure changes rapidly over small distances between zones, and MRI is susceptible to various artifacts, so interpretation requires expertise.
Understandable. Okay, this brings us to the really exciting but maybe most challenging area, cartilage regeneration and repair. Given everything we've said about its poor healing, what are we actually doing or trying to do to fix it?
This is a huge area of research, driven by that massive clinical need. The core challenge remains cartilage's limited self-repair, potential of vascular, annular, lymphatic, low cell density, slow turnover.
The familiar list of limitations.
Exactly. So tissue engineering strategies are really focused on overcoming these limitations to try and regenerate functional, durable, articular cartilage. Cell-based approaches have been used clinically for some time. One classic technique is autologous chondrocyte implantation, or ACI. You harvest a small piece of healthy cartilage from a non-weight-bearing area of the patient's knee, isolate the chondrocytes, expand them in the lab over several weeks.
Grow more cells.
Yes, multiply them significantly. Then you surgically implant these expanded cells back into the cartilage defect, usually under a patch or within a scaffold. It's shown success, particularly for larger, isolated defects in younger patients.
But it has drawbacks.
It does. It requires two surgeries, one to harvest, one to implant. It's expensive. Donor site morbidity, although usually minor, is a factor. And there's a risk the chondrocytes might de-differentiate during lab expansion, becoming less like true cartilage cells.
Okay. What about stem cells? That's always a hot topic.
Absolutely. Using autologous bone marrow-derived mesenchymal stem cells, MSCs, is a major focus. These cells can be harvested relatively easily, often from the patient's iliac crest, and they have the potential to differentiate into chondrocytes. One simpler approach, often used for smaller defects, is microfracture, or drilling. Here, you create small holes through the base of the cartilage defect into the underlying bone marrow. The idea is to allow blood and MSCs from the marrow to seep into the defect and form a repair clot, which hopefully matures into repair tissue.
Does it form true hyaline cartilage?
Usually not. The repair tissue formed after microfracture is typically fibrocartilage, which is mechanically inferior to native hyaline cartilage and tends to break down over time. So while it can provide temporary relief, it's often not a durable long-term solution, especially for larger defects or older patients. More advanced techniques involve harvesting MSCs, sometimes expanding them, and then implanting them, often within a scaffold similar to ACI.
Scaffolds seem important then, providing a structure.
Crucial. Just injecting cells often doesn't work well. They need a structure to attach to, organize within, and receive signals from. There's huge research into biomaterials and scaffolds. One interesting approach is using decellularized extracellular matrix, or DECM. You take native cartilage, perhaps from an animal source like bovine or porcine, and use chemical and physical processes to remove all the cells, leaving behind the natural ECM scaffold, the collagen, the proteoglycans, the growth factors bound within it.
So you get the natural architecture without the cells.
That's the idea. It provides a tissue-specific template that should encourage the patient's own cells to repopulate it and form new cartilage. However, it's challenging. Getting the decellularization process right without damaging the delicate ECM structure is hard. And the dense nature of cartilage ECM can actually hinder cells from getting back in effectively. Results in studies have been mixed so far.
Still needs refinement. What about really futuristic stuff like 3D printing?
3D bioprinting is definitely generating a lot of excitement. The concept is to use specialized printers to precisely deposit layers of living cells, biomaterials, bioinks, and growth factors, building up a construct that mimics the complex zonal architecture of native cartilage or even meniscus.
So you could potentially print a custom-fit cartilage patch with the right zones?
That's the ultimate goal, to create a scaffold with the right cells in the right places, maybe even incorporating gradients of growth factors to truly recapitulate the native tissue structure and hopefully restore full function. It's still largely experimental, but the potential is enormous for overcoming the limitations of current approaches.
That sounds incredibly promising. Are there other biological factors being targeted?
Yes, growth factors are key. Bone morphogenetic proteins, BMPs, are a well-known family within the larger transforming growth factor beta, TGF superfamily. They're incredibly potent inducers of both bone and cartilage formation. So modulating BMP signaling, perhaps by delivering BMP proteins directly into a defect, incorporating them into scaffolds, or using gene therapy approaches to stimulate local production, is a major therapeutic strategy being investigated. The aim is to guide MSCs towards chondrogenesis and enhance matrix production.
A multi-pronged attack then, cells, scaffolds, growth factors.
Exactly. It's clear that while cartilage is remarkably resilient in its healthy state, its poor healing makes repair a huge challenge. But the ongoing research in tissue engineering, cell therapy, biomaterials, 3D bioprinting, growth factor delivery, it offers genuinely exciting prospects for the future. This field is evolving incredibly rapidly, driven by that massive clinical need to find better ways to manage joint diseases and truly restore long-term function for our patients.
What a truly fascinating and insightful deep dive into cartilage. Thank you so much. We've gone from its microscopic building blocks, the chondrocytes and the matrix, through its complex biomechanics, the challenges of aging, right up to the cutting edge of regenerative science. It really is a tissue that continues to both amaze and challenge us in orthopedics.
Indeed, and I think understanding these fundamental principles, the A factors, the zonal structure, the slow turnover, the reliance on loading, it's just paramount for anyone involved in looking after patients with musculoskeletal problems. It helps us appreciate why some conditions are so difficult to treat effectively, and it really guides where our future research and clinical efforts need to focus if we want to make genuine breakthroughs.
Absolutely. So what does this all mean for you, our listeners working in the field? Perhaps it's a reminder, as you said, of that delicate balance within our joints, the incredible biological engineering required to maintain it, and the ingenuity needed from us when that balance is lost. It certainly makes me think differently about every joint I examine, every step a patient takes. If you found this discussion valuable today, please do take just a moment to rate and share Deep Dive Ortho with your colleagues. Your support really does help us keep bringing you these in-depth conversations.
And perhaps a final thought to consider. How might future breakthroughs, maybe in biomimicry, really understanding and replicating nature's designs, or perhaps in cellular programming, directly instructing cells what to do? How might these advancements one day allow us to regenerate perfect, native cartilage, truly transforming patient care beyond the surgical interventions we currently rely on, and maybe bringing us closer to a genuine cure for widespread conditions like osteoarthritis?